we had previously reported this FLIPI24 model in patients treated with chemoimmunotherapy to see if that could be superior to current existing prognostic models to predict the risk of early disease-related events. And because it's known that in follicular lymphoma, early disease-related events, which is commonly now known as POD24, or early disease progression, or early transformation, both of those are events that are associated with a higher risk of death in follicular lymphoma. So there's a large global initiative trying to better understand ways of identifying those patients earlier in their course to see if we can do anything to intervene or abrogate on that risk and try to modify that poor survival that they have. So last year at ASH, my colleague Matthew Maurer at Mayo Clinic developed a prognostic model called the FLIPI24, which essentially was geared towards predicting the risk of early disease-related events after starting chemotherapy. This was part of an international consortium involving multiple countries all over the world, focusing on patients with follicular lymphoma that were treated with chemotherapy. And that model was called the FLIPI24. So this model was found to be significantly better than the standard clinical models at predicting event-free survival, early event-free survival, and overall survival. And it was better than the FLIPI. So then this year, we decided to pursue the FLIPI24 in patients treated without chemotherapy. So in other words, patients who walk in the door with follicular lymphoma that undergo observation, patients who are treated with rituximab monotherapy, or patients that have a low burden of disease treated with just radiation. The idea being that if you can identify patients that who otherwise wouldn't have had chemotherapy, given that data has already been reported on, perhaps we could really consolidate both of these categories of patients to really figure out what is a mechanism of helping to stratify them at the time of their diagnosis for future events. So that was a whole kind of background behind pursuing this line of work. And so this was part of a multi-center study through a consortium called the LEO Consortium, and that stands for Lymphoma Epidemiology of Outcomes. And that's an 8-cancer center, multi-center cohort, which has been around for the last several years, looking at, it's essentially a prospective registry cohort of patients with lymphoma, where we collect different surveys, and we have a virtual biobank, and we have various different projects that are investigating outcomes after first line, second line, third line therapy. We had several different papers presented at ASH this year with results on various different populations within the cohort. So in this particular setting, we focused on the patients with follicular lymphoma, as I mentioned, that were not treated with chemotherapy. And again, wanting to understand, could we predict among those patients who will do poorly? And recognizing that there are so many models out there, is there something that we could really use to refine and adapt risk? And so what was really interesting, so we included about 1,500 patients. And what was really interesting is that we identified that this model, the FLIPI24 in this population, was much better than the FLIPI with what's known as a C statistic, which is a statistical metric of greater than 0.7. And the C statistic was much better for overall survival compared to the standard FLIPI. So what does that mean in the day-to-day? What that means is, and actually what the results demonstrated, is that if someone has a low-risk FLIPI24 score, in other words, if they're in that low-risk category, what that meant is that they had a low risk of having early progression. That risk was something on the order of less than 15%. So the implications of that is that for someone with follicular lymphoma who has a low risk of having an early event, then you may just treat them in the same way you normally would. You might consider de-escalating therapy for them. But what we found is that the patients at a high risk, FLIPI24, had poor survival. And so that ended up being an event-free survival of less than 2 years if they had a high-risk score, and an overall survival of 65%. So usually those numbers are not typical numbers that you see in follicular lymphoma. And to have a tool that could tell you that these patients at the onset will have a 2-year event-free survival, a median 2-year event-free survival of less than 2 years, median event-free survival of less than 2 years, and an overall survival of 65%. That's a group that you want to target with something potentially novel or something different, not just observation or chemotherapy. So that's probably one of the biggest take-home messages from that. And so again, as I was mentioning, what are the practical implications of this work? So I think the most important implication is that we can take this data and use it in our day-to-day when we see patients. So you see your patient with follicular lymphoma and you decide, is this person needing chemotherapy or not? And if they do, you might ask yourself, well, let's use this model, which is available online. You can just, if you Google FLIPI24 MedCalc, you can actually get this calculator online and you can plug in your patient's information. And then you can decide, wow, this patient has a risk of, let's say, 10% of having an early disease-related event. They're probably in the low-risk group. Their chances of doing well are very high. Let me approach them as I would any other person. However, someone that is in that high-risk category, you might think to yourself, well, perhaps this is an opportunity to study them in the context of a clinical trial, maybe offer them something novel, as opposed to your standard chemotherapy. So that, I would say, are the biggest highlights of that work, and I think are really exciting because it will set the stage and provide a benchmark for these high-risk patients for novel therapies.